Good afternoon, and thank you for coming to the lecture of Dr. Ananth Karamanchi. My name is Richard Levine. I'm with the Child Health Institute, and it's my pleasure to introduce Dr. Karamanchi to give you a little background. Dr. Karamanchi received his medical degree from Kilpauk Medical College and the University of Madras in Chennai, India in 1992. And he did a residency at the Henry Ford Hospital in Detroit in internal medicine from 1993 to 1996, and did a fellowship from 1996 to 2000 at the Beth Israel Deaconess Medical Center and Harvard Medical School in the area of nephrology and molecular biology. I want to say that he did, Dr. Karamanchi published a paper in 2003 in the Journal of Clinical Investigation, which in my view and the view of many others is a landmark paper on the subject of the pathogenesis of preeclampsia. And basically, I and other people think that in this paper, he discovered really the cause of the disease, and that this work is going to lead to a cure for preeclampsia and better methods of diagnosing and predicting preeclampsia. This paper was published in 2003 while he was an instructor of medicine at Harvard Medical School. And thereupon he was promoted to assistant professor. He is now an associate professor of medicine and obstetrics and gynecology at Harvard. And he has received a number of honors and awards, and I'll just list a few of them for you. He received the Dr. Asirvada Nadar Memorial Prize for the highest score on his medical examination at the University of Madras in 1991. And then he has also received the Karl Gottschalk Research Scholar Award from the American Society of Nephrology and the Young Investigator Award from the American Society of Nephrology. He received the Young Investigator Award from the International Society for the Study of Hypertension in Pregnancy. He received the Hope Award from the Preeclampsia Foundation, a Young Scholar Award from the American Society of Hypertension, an Established Investigator Award from the American Heart Association, and also a Clinical Scientist Award from Burroughs Wellcome. And he is presently an investigator of the Howard Hughes Medical Institute. And most recently, he received the Renan Tanker Foundation Award. So I'd like to introduce to you Dr. Ananth Karamanchi.
Can people hear me? Richard, can people hear me? Is the mic on? Let me see. Well, thank you. It's truly a privilege for me to be here. And thank you, Richard, for these kind words. I wanted to start out by saying that I have some disclosures. We have some patents that are licensed in this area, that are owned by the Beth Israel Medical Center and Harvard Medical School. And I'm also a consultant. So I'm also a consultant to a number of pharmaceutical companies that are actively developing products for the diagnosis of preeclampsia, and these are listed, right here. So let me start out by saying, why should we care about preeclampsia? What is this disease, and why should we study this disease? So this is one of the most common medical complications of pregnancy. It occurs in about 5 to 6% of pregnant patients throughout the world. In the United States, for example, we have of the order of 200,000 to 400,000 patients every year with this disease. And the big problem with the disease is that it has huge consequences for both the mother and the baby. So if the mother is typically diagnosed with new onset of hypertension and proteinuria, but really it's not the hypertension and proteinuria that the physicians are afraid of, is that if you leave preeclampsia untreated, the disease can progress to more serious complications. When it involves the brain, it's referred to as eclampsia. When it involves the liver, it's referred to as HELLP syndrome. And this is the mortality for untreated HELLP syndrome or eclampsia can be as high as 50%. So you're looking at very young women, essentially with almost no medical problems, presenting with this disease with such huge odds of dying. And as a result, this disease has attracted enormous attention, particularly in the third world, where this is thought to be either the #1 or the #2 cause of maternal death. It also has a huge consequences for the baby because the only treatment for the disease is delivery of the placenta. If in fact you can treat the patients by delivering the placenta, why can't we just deliver everybody? The problem is that about a third of patients with the disease present prematurely, at about 25 or 26 weeks of pregnancy. And if you deliver these patients at 25, 26 weeks of pregnancy, you end up having a very premature infant, and particularly in third world where there are no good ICU care, the babies can die. So clearly, this is a very important disease from both maternal and fetal morbidity and mortality standpoint. It's important for us to understand, what causes the disease, and can we molecularly understand the pathway that mediates these signs and symptoms, and if so, can we design rational therapies for this disease. The big sort of advance in the field was made in the late 1980s by Jim Roberts' group, from at that time from UC San Francisco, when they made the observation that the most likely cause of the disease is a circulating factor released by the placenta. And they made the the hypothesis that this circulating factor, induces endothelial dysfunction and vascular damage selectively in these organ beds. For example, if you look at the kidney, they have a very classic histological lesion that's referred to as glomerular endotheliosis. This is the damage of the glomerular capillary endothelial cells, and really this damage leads to proteinuria and eventually can lead to significant renal failure. Likewise, in the brain, there's disruption of the blood-brain barrier, and you can get edema in the posterior aspects of the brain, a syndrome that's referred to as reversible posterior leukoencephalopathy. And this syndrome is not particularly, typical of eclampsia. You can see this in a number of vascular disorders. For example, TTP, which stands for thrombotic thrombocytopenic purpura, or acute cyclosporin toxicity. These vascular disorders can also have similar patterns of injury in the brain, where you have this edema in the posterior aspects of the brain. Likewise, in the liver, it's the hepatic sinusoidal endothelial cells that are affected. So it's not a surprise that if the signs and symptoms typically get better when the placenta is delivered, and since the placenta per se is not directly in communication with any of these organ beds, that in fact it's a circulating factor. Roberts and Taylor very elegantly suggested that if you take plasma from patients with preeclampsia and you expose them to endothelial cells in culture, you can activate the endothelial cells, but this phenomenon was not seen in normal pregnant patients. So suggesting that clearly there must be a factor or multiple factors liberated by the placenta. So how does one go about studying this? It turns out that for years and years people are trying to purify these factors using biochemical assays, and really were unsuccessful. And so the hypothesis we took is, why don't we try to approach this molecularly? And in about early 2000 and 2001, the technology of microarray was just coming out, and these placental tissue were fairly easy to obtain. So our laboratory just started, and we collected these placentas from normal and preeclamptic placentas, and simply looked for all the secreted proteins that the preeclamptic placentas were making, and particularly focused on those molecules that had let's say a vascular smell to it, because the phenotype of the disease was a vascular disease with the glomerular capillary disease, or lesions in the brain or lesions in the liver. So the hypothesis was that the placenta is diseased, for unknown reasons, from genetic or other immunological factors, and the diseased placenta releases these soluble mediators that in turn causes the maternal syndrome. And so why do I say that the placental disease is primary? Because most people believe that the abnormalities in the placenta, happens very early in pregnancy, even as early as 12, 13 weeks of pregnancy, whereas typically the hypertension and proteinuria and some of the other signs and symptoms of preeclampsia occurs after 20 weeks of pregnancy. So most people believe that the primary cause of the disease is the placenta, and the placenta in turn secretes these factors, which in turn cause the clinical disease that we refer to as preeclampsia. So the factors that we're going to talk about are factors that regulate angiogenesis, which is the formation of blood vessels from pre-existing blood vessels. And so I wanted to give you a little overview of this field. Even though angiogenesis was first described in the placenta as early as 1930s, really the bulk of attention has been focused primarily as it relates to cancer. And cancer tissues, in order for them to proliferate and metastasize, secrete factors, soluble factors, that in turn induce new blood vessel formation through a process called angiogenesis. And one of the key, and this for example is a tumor, and one of the key molecules that were discovered as an important molecule that induces new blood vessel formation is this protein called VEGF, which stands for vascular endothelial growth factor. And this is one of the most abundant proteins made by pretty much every cancer tissue that one has looked at. And this protein in turn forms new blood vessels, and this in turn results to the cancer tissue growing bigger and eventually metastasizing. And this obviously is very important in the tumor field, primarily because one can antagonize VEGF, and there is an approved drug now called Avastin, which is an antibody against VEGF that one can use for the treatment of metastatic cancer, and it's been approved now for metastatic colon cancer and a few other cancers like breast cancer as well. So the protein that on microarray, one of the first proteins that we found in the placenta that was massively upregulated in patients with preeclampsia was this protein called soluble fms-like tyrosine kinase 1. Or also it's referred to as SFLT1. It's also referred to as soluble VEGF receptor 1. And this is a soluble receptor for the vascular endothelial growth factor group of proteins. So it turns out that VEGF binds to a number of receptors. It binds to a receptor called FLT1 that's present on endothelial cells that's primarily thought to mediate the vascular homeostatic functions of vascular endothelial growth factor. VEGF also binds to another receptor called KDR, which is VEGF receptor 2, that in turn induces new blood vessel formation. And there are other additional receptors like neuropilin, etc. But it turns out that the placenta makes an interesting protein called soluble FLT1. This is an alternatively spliced transcript that lacks the transmembrane in the cytoplasmic domain, and for the most part is primarily made by the placenta. And this protein, because the extracellular domain is identical to the extracellular domain of the FLT1 protein, can act as a sink. In other words, it can bind VEGF or VEGF-like molecules such as PlGF, which stands for placental growth factor, and essentially, as a sink, it can mop up these molecules and create a deficiency of these proteins. And one would think, why would the placenta make such a protein? And there shouldn't be a surprise, because if you really look at the placenta, it's almost like a bag of blood vessels. You have fetal blood vessels on one side, maternal blood vessels on the other side, and as the placenta keeps growing to keep up the demands of the baby, it makes a lot of VEGF and VEGF-like molecules like PlGF, and these proteins are made for physiological angiogenesis to go on in the placenta in every normal pregnancy. And towards the end of pregnancy, how do you sort of, rather than produce less of VEGF and less of PlGF to stop the angiogenesis, it makes more of these soluble receptors. So this is a sort of accelerator and a brake sort of phenomenon that's going on in every normal pregnancy, where you have a lot of these angiogenic proteins early on in pregnancy, and towards the end of pregnancy you have these anti-angiogenic factors essentially that act by binding these growth factors and creating a deficiency. And what we found was that the patients with preeclampsia had significantly upregulated message for soluble FLT1 in their placenta. And this was particularly exciting because we know that the phenotype of the disease was a vascular disease, and if this protein was soluble and potentially secreted into the bloodstream, in theory this could induce vascular damage. And again, even though VEGF has primarily attracted its attention in the angiogenesis field, and people had known for years that this molecule also has homeostatic functions in the vasculature. For example, it maintains vascular tone. It can also has additional functions, for example, the formation of endothelial fenestrae, which we'll talk about, that occurs even in resting vasculature that is not undergoing active angiogenesis. So the hypothesis is that in normal pregnancy, you have these growth factors like PlGF or VEGF that are being made, that are seen by normal blood vessels, and the blood vessels in turn are healthy and happy, and it maintains a vasodilated state. In patients with preeclampsia, you have a lot of these soluble receptors that captures these growth factors. As a result, blood vessels no longer see these growth factors, and we think this in turn induces endothelial dysfunction and potentially the clinical phenotype of preeclampsia. So let me show you a little bit of the data that confirms this hypothesis. So this is ELISA for soluble FLT1 taken from blood samples obtained from patients with preeclampsia, and with normal pregnancies prior to delivery. So you could look from this graph, it's pretty obvious that patients with preeclampsia have maybe 3 to 5-fold elevated levels of soluble FLT1 prior to delivery. But importantly, when the placenta is delivered, 48 hours after the placenta is delivered, it falls acutely, suggesting that this protein is made in normal pregnancy for a physiological function, but that in patients with preeclampsia, it made at even higher quantities. Now, if in fact soluble FLT1 is circulating at high quantities, does it in fact inhibit, let's say, VEGF signaling in the kidney or the brain, and how would you sort of prove that? And the problem is that it's impossible to get sort of renal tissue or some other tissue to actually ask the question, is in fact VEGF signaling being compromised in these target organs? As a surrogate, one can actually measure free concentrations of these growth factors such as VEGF or PlGF. And using an ELISA that only measures uncomplexed VEGF or uncomplexed PlGF, you can actually demonstrate quite nicely that patients with both severe preeclampsia or mild preeclampsia have significant drops in free concentrations of these growth factors. So this is a surrogate of really potentially what's going on in the maternal target organs. So as soluble FLT1 goes up, the soluble receptors build up in the bloodstream, they bind these growth factors and essentially create a deficiency of these growth factors. And this obviously was quite exciting to us. From a diagnostic standpoint, the PlGF really attracted a lot of attention because it's present at huge quantities in normal pregnancies, and really one doesn't even have to dilute the samples, and you could get pretty robust values from a diagnostic standpoint. And several of the obstetricians were quite excited that could you actually use S-FLT concentrations or PlGF to actually diagnose preeclampsia, and I'll show you some data sort of to back up that idea. So the hypothesis is that the placenta makes excess quantities of soluble FLT1, and this in turn antagonizes the growth factors, which in turn lead to widespread maternal vascular endothelial dysfunction. But why, if you had a factor that destroys, let's say, endothelial cells, why should it first affect the kidney? Why does preeclampsia start in the kidney? Why does it not start in the spleen or the skeletal muscle? Because they also have blood vessels. What's so special about the vasculature in the kidney? And why does it affect the brain or the liver? And so this was a puzzling question, but it became quite apparent the reason that the kidneys are first affected in patients with preeclampsia is that's where vascular endothelial growth factor is highly expressed normally. So in the absence of angiogenesis, if you take a normal adult and ask where is vascular endothelial growth factor expressed, the highest expression is across fenestrated vasculature, such as the glomerular capillaries, or in the kidney, or in the choroid plexus, or across the hepatic sinusoids. And these vasculature are uniquely differentiated. They have what's called as endothelial fenestrae, which are transcellular communications that allow for fluid and water to be transported. And so here's a structure. Here's a picture taken from a paper where the VEGF gene, where LAG-Z gene was knocked into the VEGF locus, and you could see a normal adult mouse that's abundantly expressing VEGF in the glomerular podocytes, even though there's no active angiogenesis going on. So clearly, these structures are normally seeing a lot of the growth factors, and a lot of active signaling is going on there. So if you have an endogenous inhibitor, the phenotype likely will start in organs where there's constitutive signaling happening. So just to back up, so why is VEGF expressed in these organs such as glomerulus of the kidney, even though there's no angiogenesis? And to sort of really get at this question, you have to go back at some of the old literature. It turns out that George Palade, and this is a paper actually from Werner Rizzo, had actually done some very nice work where they had shown that of all the growth factors that are present that act on endothelial cells. One of the most potent molecules that causes endothelial cells to differentiate and form this endothelial fenestrae is vascular endothelial growth factor. And let me explain to you what the endothelial fenestrae represent. These are essentially thinning of blood vessels, thinning of endothelial cells, so that it becomes relatively thin, so it allows for fluid and water to be transported from, let's say, the vascular compartment into the interstitial space. And you sort of need that in the glomerulus, because otherwise that's the first sieving barrier against proteinuria, and that's how you form urine. Likewise in the choroid plexus, that's how you form CSF, and like similarly in the liver, that's how you get transport of toxins across into the hepatocytes for detoxification. So these vascular beds are specifically differentiated to form fenestrae, and one of the molecules that, at least in cell culture, induces endothelium to form fenestrae is VEGF. And in fact, we had known for years, even at least 5 years before we first published our work, that if you biopsy preeclamptic patients' kidneys and look under the microscope, the most consistent observation that you find on a renal biopsy is a loss of glomerular endothelial fenestrae. You see less fenestrae and less fenestral density, and really, if you go back and ask the question, what maintains the fenestrae, it's a constitutive expression of VEGF. So it's not a surprise that if you in fact have soluble FLT1 circulating, that in fact might lead to this phenotype. One has to sort of prove that. So we did this experiment using an overexpression system, where we overexpressed using an adenoviral expression system, where we expressed soluble FLT1 at concentrations that are present in patients with preeclampsia in both pregnant animals and non-pregnant animals. And you could see that you get massive proteinuria. And it didn't really matter whether this was given to a pregnant animal or a non-pregnant animal. And the reason why this is a pregnancy-specific disorder is, in fact, this protein is made primarily by the placenta. And in this case, in this artificial experiment, we gave it exogenously, and you can get the disease even in a non-pregnant animal, suggesting that you don't require the placenta to create this sort of renal phenotype. You can also have significant hypertension. But one of the things that's apparent to nephrologists is that whenever you have hypertension, you have a little bit of proteinuria. What's so special about preeclampsia is that they have this classic histological lesion that I referred to as glomerular capillary endothelial damage that's fairly specific for preeclampsia. Not a lot of human diseases give that pattern of injury. And we wanted to see if we can reproduce the renal histological changes that we saw that we have seen in human preeclampsia in our animal model. And so this is the PA stain of the glomeruli of our rats exposed to a control protein or soluble FLT1. And these are the corresponding electron microscopy. And the bottom line is that this pattern of injury, where you see these swollen PAS negative cells and these pinkish droplets or protein resorption droplets, is fairly reminiscent of what one would see from a biopsy taken from a patient with human preeclampsia. And to confirm that in fact it's endothelial swelling, you can actually do an electron microscopy, and this is a normal rat glomeruli, where you see the glomerular capillary lumen wide open, and this is the urinary space. The spiky structures here are the podocytes, foot process of the podocytes that make VEGF, and VEGF acts on the endothelial cells to form these fenestrae that are situated on the endothelial cells. And this is what happens in a normal rat. This is what happens in a normal human. And what you see in preeclampsia is massive endothelial swelling. You don't see a whole lot of immune complexes. And this sort of bloodless glomerular injury pattern is very consistent with what we see in human preeclampsia. In fact, you can reproduce the same phenotype by knocking out VEGF only in the kidney. And this was work done from Susan Quaggan, a nephrologist back in Toronto, where she conditionally knocked out VEGF just in the kidney. And what you see is that, so this is a normal, mouse glomeruli. These are the podocyte foot processes, and these are the endothelial fenestrae, and this is a large red cell in the capillary lumen. And typically, blood is filtered past the fenestrae, past the basal membrane, and into the urinary space between the foot processes. And what you see in an animal that lacks just one allele of VEGF in the kidney, you see almost complete capillary occlusion. You no longer see lumen, and you almost see a complete loss of endothelial fenestrae. And this pattern of injury is exactly what we see in human preeclampsia. This is what we see in our animals exposed to soluble FLT1. There was, interestingly, at the time when we were sort of developing this work, there was interesting work coming out from the cancer literature that patients exposed to a variety of VEGF inhibitors, be it antibody against VEGF or small molecule inhibitors of VEGF for the treatment of cancer-related metastasis. A number of those patients were getting preeclampsia-like signs and symptoms. They were getting hypertension, proteinuria. Some of them were getting even this edema on MRI scans in the brain that looked just like what we see in patients with eclampsia. And this was not restricted to just an antibody against VEGF, also small molecules that were blocking VEGF receptor tyrosine kinases, but also seeing similar sort of patterns of injury. And a number of reports in the New England Journal and some reports in the cancer literature. And so this suggested to that, in fact, if you inhibit VEGF in a normal adult, you can get hypertension, you can get proteinuria, and that's likely what was going on in preeclampsia, because there was an endogenous VEGF inhibitor called soluble FLT1 that was being made by the placenta. There was still an issue, there was still quite a bit of skepticism at the time as people weren't clear whether this was going to be a cause or an effect of the disease. In other words, when you have renal damage from preeclampsia, maybe proteins build up as a result of decreased glomerular filtration rate, and maybe the proteins that we see, for example, soluble FLT1, could be a consequence of the disease. And how do you know this is a cause or an effect? And one of the ways to ask the question is to try to ask, can you show that in patients who will develop the disease that you can actually show alterations of these proteins prior to onset of any signs and symptoms? And we were fortunate at that point to collaborate with Richard Levine, who's sitting here in the audience, who had done a fascinating study in the mid-90s looking at the role of calcium in preeclampsia. And this was a large NIH-funded study. And the important thing was that even though the study was negative, they were smart enough to collect blood samples and had stored them in the freezers. And using a nested case control design with Richard was able to show that patients with preeclampsia were seeing elevated levels of soluble FLT1 even before onset of signs and symptoms. So T is equal to 0 is a time when a woman first gets hypertension or proteinuria. These are data points taken when a woman's seeing a doctor, obstetrician for a routine visit, and really has no hypertension or proteinuria. And you could see even before any symptoms, approximately a month or so before onset of symptoms, you could start seeing rises of soluble FLT1. Likewise, you could see a fall in free PlGF even a month or two before onset of signs and symptoms. This likely suggested to us that most likely that these proteins were involved in the causal pathway, and they were probably mediating the hypertension as well as the proteinuria of preeclampsia. So this was obviously quite exciting. If in fact these biomarkers are elevated prior to the development of clinical symptoms, this could be used as a diagnostic or even as a predictive test. But most importantly, if in fact these were causal, they were involved in the causal pathway, could we antagonize these proteins and thus try to see if we can prolong pregnancy even by 2 or 3 weeks? So rather than a woman delivering at 25 weeks of severe preeclampsia, have it deliver at 28 or 29 weeks where the baby has a better outcome. And so really our lab has been focused primarily in this area to try and see if we can develop a better rational therapy for preeclampsia. Let me share with you some unpublished data that we've recently worked in terms of trying to see if can this be useful as a diagnostic test. And so working with a number of pharmaceutical companies, in this case this is data from Beckman Coulter, they actually were able to take these assays, soluble FLT1 and PlGF, and were able to place it on an automated platform. And this is initial data looking at the first 100 patients or so, presenting to Abbott Northwestern Hospital in Minneapolis with signs and symptoms of preeclampsia. And what you could see is that these molecules, in this case soluble FLT1 or PlGF, and there are two different formats of it, free or a total soluble FLT1. Bottom line is that the ROC curves were quite good, very robust. The values were 0.969, 0.968, and they were quite good in terms of identifying these preterm, premature preeclampsia. And so this is how these curves are typically plotted, where you plot sensitivity against 1 minus specificity. And if you had a terrible test, essentially, you have it's around 0.5. And if you had basically an outstanding test, you had a number of around 1. And essentially these markers were quite useful. But obviously this is a small study, and one needs to sort of confirm this in larger patients, maybe several thousand, to see if in fact can this be useful. just to show you the actual raw data, and this is plotted on a log scale, and so this is soluble FLT1 concentrations, and you could see for the most part the soluble FLT1 concentrations on an average are about 10 times to maybe higher, 10 to 20 times higher than the mean concentrations of normal pregnant patients. But there's clearly a couple of patients, for example, who have preeclampsia but have low values. There are a couple of patients who are normal pregnant patients that have relatively high values. And what's interesting is that at the moment the clinical diagnosis is fairly inaccurate, and even though it's the gold standard, it's based on hypertension and proteinuria, and nobody really does a renal biopsy to formally document preeclampsia. And our own feeling is that when people have done those studies, typically the clinical criteria only correlates 70 to 80% of the time, and there's usually 10-20% false positives. And our own feeling is that these are actually false positives. In fact, they may not truly represent preeclampsia, and these may actually represent preeclampsia. And obviously one does not know that. We have to sort of follow these patients prospectively and see what their outcomes are, both maternal and fetal outcomes. But what about trying to antagonize this protein and trying to see could you actually develop a safe therapy for preeclampsia? So one strategy that we were able to use, we were fortunate to be able to work with a small biotech company up in California, called Sios, that had rights to a protein called VEGF-121. It turns out that this protein VEGF-121 was ideal because it lacks the heparin binding domain, and so as a result, when given subcutaneously, it has a wonderful pharmacokinetic profile, and it can be given once a day. In theory, we thought if this were useful, one could deliver this in the third world, fairly easy. And so to simply ask if this would be useful in our model of preeclampsia, we did a very simple proof of concept study where we would take our animals, expose them to soluble FLT1 and create preeclampsia, and then randomize them to get either this drug VEGF-121 or control drug. So the idea is that this VEGF-121 would bind soluble FLT1, and as a result soluble FLT1 will no longer be able to neutralize the VEGF in the kidney and brain and liver, etc. And would this be safe? And the bottom line is that we saw quite nice changes in blood pressure. Blood pressure significantly improved in the animals exposed to VEGF-121, where the control preeclamptic animals had significant increase in blood pressure. And the proteinuria almost completely resolved. And importantly, we also started seeing improvement in glomerular histology, suggesting that in theory, at least this might be useful. But one of the problems of such a drug is we don't know if this would cross across into the fetus and might have untoward side effects in the baby. And really, it's very difficult to study this in rats, primarily because the pregnancy in rats is about 21 days. Human pregnancy is obviously several months, and one doesn't know if acute exposure to a protein for 2 or 3 days is the same as giving a drug for a month in patients. Nevertheless, we took a look at the fetuses. There was really no effect on the fetus, the placental weight, and really did not appear to cross across the placental barrier, as the molecular weight of this protein was quite high, and really typically proteins that are above 5 kilodaltons don't typically cross across unless it's an antibody sort of mediated transfer. But nevertheless, we don't know if such a therapy, for example, would be safe in humans, and one has to really study this in models of preeclampsia that more closely mimic human preeclampsia, such as in primates. So we quickly developed a collaboration with a group in Australia that's actually developed an interesting model of preeclampsia in a pregnant baboon. And these baboons typically have a pregnancy of about 180 days or so, and the way you create preeclampsia is this is a very artificial maneuver where you typically you give them you infarct the placentas, you do a digital subtraction angiogram and essentially embolize 20 or 30% of the placental cotyledons, and immediately within 24-48 hours of creating placental ischemia, these animals get massive preeclampsia-like signs and symptoms. They get hypertension, proteinuria, and they have histological lesions that look like preeclampsia. So let me share with you some of the data, and like you see right after the right after this uteroplacental ischemia, these animals have increase in blood pressure, both systolic and diastolic. They also have significant increase in proteinuria, both total protein or albumin creatinine ratio. And importantly, they have a significant increase in plasma soluble FLT1 concentrations. So this would be a wonderful model for us to sort of test not only efficacy of our drug against preeclampsia, but also some of the side effects, if there are any effects on the baby. At the moment, we're still sort of working with this group to try and figure out if, in fact, soluble VEGF 121 could be useful in this model. And this model also has features just like human preeclampsia, where they can have this massive endothelial swelling and also some fibrin deficits that look like what we see in human preeclampsia. So let me summarize this aspect of the talk by saying that the patients with preeclampsia have high circulating levels of this endogenous inhibitor of angiogenesis called soluble FLT1. We know how it works. It works by simply depleting VEGF and VEGF-like molecules like PlGF. And that in fact, when you give it to animals, it is sufficient to induce hypertension, proteinuria, and glomerular endotheliosis. And potentially, if you antagonize these proteins soluble FLT1 with VEGF or an antibody, this might be useful for, as a therapeutic for preeclampsia. And finally, these markers potentially may serve as diagnostic or prognostic markers. Although, as I said, a lot of the studies that we've done with Richard Levine at the NIH were mostly retrospective studies, and really, we don't really have good prospective data to answer the question whether these markers may be useful. So I want to switch gears a little bit and talk to you about a more recent discovery in our laboratory about a new protein that we've identified in the laboratory that plays a very synergistic role in preeclampsia, and this is a protein called endoglin. It turns out that endoglin was first described in the early 90s by Michel Letarte at the University of Toronto as a protein that's primarily made in endothelial cells as a TGF-beta co-receptor. But in fact, in her original paper, she described that the highest expression of this co-receptor was in the sincere trophoblast of the placenta. And this is the layer of the placenta that is in intimate contact with the maternal blood. In other words, if this protein were to be released into the bloodstream, this would be present in enormous quantities in the mother's bloodstream. And what was also interesting to us was that, in fact, this protein physically interacts with endothelial nitric oxide synthase. And if you take an endothelial cell and knock out endoglin, the endothelial enos is poisoned. In other words, if you give enos L-arginine, you primarily get uncoupling and you get oxidative stress. You get lots of O2 minus, etc. And really, it seems like endoglin is necessary for normal endothelial nitric oxide function. And people have suggested, at least in preeclampsia literature, that there were decreased nitric oxide activity in the placenta, as well as in the circulating mediators of nitric oxide activity in the patient's bloodstream. And so we thought maybe this was this might play a role in preeclampsia. But the important reason why we thought this might play a role in preeclampsia was that our animal models were explained only a part of the preeclampsia phenotype. We could never get full-blown preeclampsia. In other words, we did not see eclampsia, we did not see HELP syndrome in our animal models. And importantly, there were patients, at least some patients, who had relatively normal levels of sFLT1 and were still getting preeclampsia-like signs and symptoms. And the question is that, are there additional molecules? Is it a different pathway? Or in fact, the vasculature is damaged to begin with, that they might even react to sort of normal-ish levels of sFLT1. And when we went back to the microarray, this particular protein seemed to track quite nicely with soluble FLT1. Every patient that seemed to have high levels of sFLT1 also seemed to have increased upregulated levels of endoglin. And importantly, very much like soluble FLT1, that there was a soluble isoform, at least described in the cancer literature, as part of tumor-related angiogenesis that was being shed, a protein called soluble endoglin. And it turns out, at least we don't know for a fact how the soluble endoglin is being made. We think it's being cleaved at the extracellular domain at this amino acid by specific metalloproteases present in the placenta. It's also possible that this could be an alternatively spliced transcript, but again, work in a lab is still ongoing in that area. But the bottom line is that there is a soluble piece of the endoglin that essentially shed and acts as an anti-angiogenic molecule by essentially blocking TGF-beta and other molecules such as BMP signaling in the vasculature. Let me show you a little bit of the data to sort of take you through this hypothesis. So this is preeclamptic placenta, and these are normal placentas. Essentially, these are term preeclampsia, these are preterm preeclampsia. And what you see is there's increased levels of endoglin message in patients with preeclampsia. And in fact, this translates, you could see that the sincere trophoblasts are massively upregulated with endoglin, and it's really not the cytotrophoblast, it's really the sincere trophoblast. This is the one that's in direct contact with the vascular space. And very much like soluble FLT1, there is a soluble piece of the endoglin that is shed and that is present in circulation. You could see compared to normal pregnant patients, patients with preeclampsia have about maybe 3 to 5-fold elevated levels of soluble endoglin. And after the placenta is delivered, it significantly drops. And this is taken in 48 hours. And if you wait for a week or so, you could see that the concentrations in a non-pregnant state is quite low, of the order of 2 to 3 nanograms per mil. Whereas in patients with severe disease, some of them have a concentrations as high as 100 nanograms per ml. So what does soluble endoglin do, and why is it present in patients with the disease? In the interest of time, I will summarize the in vivo data without going into some of the in vitro sort of biology. The bottom line is that soluble endoglin, when you give it to a pregnant animal, other than a slight increase in blood pressure, doesn't do a whole lot of, it doesn't really give a phenotype. The animals are quite happy. But if you take the pregnant animals that are already exposed to high concentrations of soluble FLT1, and then you expose it to soluble endoglin at concentrations present in patients with the disease, you essentially get full-blown preeclampsia. You get significant hypertension, massive proteinuria. You start seeing evidence of HELLP syndrome, which is characterized by low platelets, increased liver enzymes, as well as hemolysis, as shown by increased LDH, and finally fetal growth restriction, which is a very common feature of severe disease. And this was quite attractive to us, that maybe there are synergistic molecules being made by the placenta that act on the vasculature to induce full-blown disease. And this is a histology of the liver. For example, you could see animals exposed to S-FLT1 and S-endoglin have liver infarction and also have hemolysis. These blue cells are the reticulocytes. These fragmented cells here are schistocytes. And typically the hemolysis is not as extensive as you see in patients with TTP. You see a mild degree of hemolysis from endothelial injury. And you can also see placental infarcts, and these are placental sections, and this is an extreme case of a large vessel in one of these animals' placenta, and you could see there's an infarct happening. And similar infarcts can be seen in patients with preeclampsia. If you take human placentas, they're typically small. You see a lot of infarcts, and maybe we thought this might explain why these patients are significantly growth restricted. And more recently, we've also shown that if you take mice and give them high concentrations of soluble FLT1 and soluble endoglin, you can also see patterns of edema in the posterior aspects of the brain that look just like what we see in human eclampsia. So this is referred to as reversible posterior leukoencephalopathy, where you see edema leaking in the posterior aspects of the brain. Similar patterns of injury has also been seen, as I pointed out, in cancer patients getting molecules that resemble S-FLT1, such as the VEGF receptor inhibitors or an antibody against VEGF. But what about patients with preeclampsia? Are there a subgroup of patients that primarily express endoglin, or is it S-FLT1? And is this the cause or an effect of the disease? We went back to Richard, and Richard was able to do this analysis back in the CPEP cohort. And what was very interesting was that patients with preeclampsia, and this is a particular subtype of preeclampsia that's referred to as early onset disease, and these are the patients who have more severe and serious complications. When you look at this group of patients in particular, you could see that the soluble endoglin starts going up, weeks or at least 1 or 2 months before onset of any signs and symptoms, in contrast to normal pregnant patients who are more or less flat and who have a slight increase towards prior to delivery. So is there an interaction of these proteins in patients? And to look at that, we asked the question, what happens to patients who have only high levels of soluble FLT1, but actually have normal or low levels of endoglin? And likewise, what happens to patients with high levels of soluble endoglin, but low levels of S-FLT1? And what about patients with high levels of both? And these are samples taken approximately a month or so before onset of any clinical evidence of preeclampsia. And if you look at patients who have high levels of soluble FLT1 and low levels of soluble endoglin, the chance of getting preeclampsia is about 2.3-fold. So it's modest. If you have patients with high levels of soluble endoglin but low levels of S-FLT1, their chance of getting preeclampsia is about 1.5-fold, which is also modest. But if you have high levels of both, the chance of getting preeclampsia is quite high. It's about 31-fold. And this is really the group of patients. In fact, every patient with preterm premature preeclampsia in this study, except for one patient, fell in this category. Basically having severe, but high levels of both proteins causing severe premature, preeclampsia. Now, from an epidemiological standpoint, one could ask the question, we've shown that there's a very strong association between these proteins and the onset of the disease. We've also shown that there's what about the severity of the disease? Can you show that in fact there's a dose response between these proteins and the severity of the disease? And what is shown here is that if you measure soluble FLT1 and soluble endoglin or free PlGF, the bottom line is that the most dramatic changes of these proteins are seen in these patients who have severe early disease, like preeclampsia that present at less than 34 weeks, or preeclampsia that presents with severely growth-restricted babies, compared to mild preeclampsia or controlled pregnant patients. So not only is there an association between the presence of S-FLT1 or S-endoglin and preeclampsia, but in fact, the higher the values, the more severe the disease is. From an epidemiological standpoint, we can also ask the question, could we explain the known risk factors of preeclampsia based on the knowledge that these proteins may be involved in the causal pathway? So one of the important risk factors for preeclampsia is multiple gestation. The incidence of preeclampsia is about 5% in normal pregnant patients. In patients with twin pregnancy, the incidence can be as high as 15% or so, whereas in patients with triplets, it can be as high as 25% to even 30%. And why is that? If you look at that, if you look at soluble FLT concentrations, throughout pregnancy, compared to singletons, twins and triplets have much higher concentrations, throughout pregnancy, and this is really related to a mass effect. In other words, there's nothing special about these placentas, that in fact they have more placenta, and as a result they make more soluble FLT1. The amount of VEGF is constant in the maternal mother's kidney or in the brain, and really now the threshold to develop the disease is lowered because you have higher concentrations of this circulating inhibitor VEGF signaling. In fact, if you just replace this with soluble endoglin, essentially you get a very similar sort of pattern. There's another sort of unique disease that is not a common disease that we see anymore. It's a disease called trisomy 13. So these are fetuses that have an extra copy of chromosome 13. These fetuses are typically diagnosed as early as 11 or even 17 weeks by triple screening and amniocentesis, and most of these pregnancies are terminated. But in those pregnancies that are not terminated, if you look at the old literature, the incidence of preeclampsia in these pregnant patients who carry a trisomy 13 fetus is 50%. And so why is that? And this was quite fascinating. Yuval Badola, an obstetrician from Israel, was at that time working in my laboratory and sort of brought this condition to my attention, and it became quite apparent that this may be explained by high levels of soluble FLT1, because the gene for soluble FLT1 or FLT1 is in chromosome 13. If in fact the placenta had an extra copy of chromosome 13, potentially there's a 50% higher levels of soluble FLT1 in the maternal circulation, and this might, again, just like the twins and triplets, might explain why the threshold to develop preeclampsia is significantly lowered. And so to look at that, we collaborated with a group in Maine who had access to a number of blood samples from a variety of karyotypes, and you could see, compared to all the other karyotypes, the trisomy 13 was the only one that had a pattern of S-FLT1 and PlGF that looked like what we see in patients with preeclampsia. What about smoking? It's known for years that every major epidemiological study has suggested that patients who smoke during pregnancy are protected from preeclampsia. Now, obviously this is not something that the obstetricians would like to advertise because the smoking has other untoward effects on the baby, such as growth restriction and potentially other epigenetic changes that can be long-term in these babies. But every sort of epidemiological study has suggested that people who smoke, are protected from preeclampsia. And to sort of look at that, we asked the question, what about soluble FLT1 concentrations in these patients who smoke versus those who don't smoke? And you could see there's, on an average, there's about 10 to 20% reduction of soluble FLT1 throughout pregnancy amongst the smokers. Why is that? Some very exciting data from Asif Ahmed's group at from UK has suggested that in fact, small concentrations of carbon monoxide in smoke can be a vascular protective agent, and in fact, through a complicated signaling mechanism, these low concentrations of carbon monoxide can actually inhibit placental production of soluble FLT1. That might explain this sort of mystery as to why smokers are typically protected from preeclampsia. So in summary, what I've shown to you is that the diseased placenta secretes these toxic proteins called soluble FLT1 and soluble endoglin. They're primarily made by the placenta. There's some evidence in the literature that other cell types such as circulating monocytes might also make, but really the bulk of the contribution is from the placenta. And they fall after delivery as soon as the placenta comes out. And these proteins, when you give them to animals, can create full-blown preeclampsia like hypertension, proteinuria, growth restriction, HELLP syndrome, and even features of cerebral edema that look like eclampsia. And that these markers are present at the time of the disease. They're present approximately a month or so before onset of signs and symptoms. So potentially they may serve as diagnostic or predictive markers. But importantly, if you were able to antagonize these proteins, potentially we might be able to prolong pregnancy by 2 to 3 weeks. So this is actually a wonderful, attractive area to study therapeutics, because you're not looking at long-term drugs like you typically use in cancer or in other sort of chronic conditions. Here, this is an acute condition, and all you're looking for is trying to prolong pregnancy by a month, 2 to 3 weeks or so, and the outcomes is night and day when you deliver a baby at 30 weeks versus when you deliver a baby at 25 weeks. So we are hopeful that this knowledge at some point will lead to a therapeutic benefit in these patients with the disease. So in summary, our hypothesis is that there's physiological angiogenesis going on in placenta normally, and that's mediated by a number of players, and the important ones are VEGF and PlGF, but obviously there are other sort of molecules that are also involved. And that and towards the end of pregnancy, when it's time for the placenta to stop growing and prepare for delivery, rather than make less of these proteins, it makes endogenous anti-angiogenic proteins. These are typically soluble receptors that bind these growth factors and essentially create a deficiency. And that in patients with preeclampsia, this curve is shifted to the left because they make too much of these soluble proteins too soon. So what about the future? Where is this? These results? What do I see happening in the next sort of 3 to 5 years? I think the important thing is that at the moment the clinical diagnosis of preeclampsia is fairly inaccurate. In at least 10 to 15% of the time, there are false positives and false negatives. So if you wrongly diagnose a woman with preeclampsia, you're unnecessarily delivering them, so you're left with a premature baby. Likewise, if you miss a diagnosis of preeclampsia, you in turn can have consequences, because the mothers can have serious complications of preeclampsia. So one needs sort of a biochemical pattern of diagnosis, but importantly, particularly in those patients that look like preeclampsia, patients who have, or pregnant patients with chronic hypertension, or pregnant patients with a history of, or who present with thrombotic thrombocytopenic purpura. So, one needs more data actually to ask the question, do these markers help differentiate preeclampsia from these other conditions that resemble preeclampsia? And importantly, I'm hopeful that some of these markers will get incorporated with other measures of prenatal care, such as Doppler ultrasounds and simple sort of, other sort of physical characteristics like body mass index, into potentially a way to predict who is going to get the disease, and as a result triage these patients to high-risk OB clinics that take care of preeclampsia. This is particularly useful in the third world, where you don't have lots of high-risk maternal fetal medicine specialists. So if you could identify these patients from a rural community that they're at very high risk for getting preeclampsia, one can sort of turf these patients to district hospitals that actually have reasonable ICU care if these kids were born prematurely. But I think the most exciting thing is that these markers are not epiphenomenon. They're in fact involved in the causal pathway that mediates these signs and symptoms. So potentially, if we could develop a therapy that is safe, this would be a tremendous advance to the field, particularly to allow improved outcomes for the babies as well as the mothers. And finally, a number of laboratories at the moment are interested in asking the question, why are these proteins being turned on in normal pregnancy, and why is it abnormal in preeclampsia? And there's lots of exciting literature that this might be linked to excess angiotensin II signaling, might be linked to hormonal imbalances in the placenta, and may possibly genetic alterations. It really one that really doesn't know, and this is going to be an exciting area in terms of asking, why do these alternatively spliced proteins, why are they made at such high quantities in normal pregnancies and even higher quantities in patients with preeclampsia? And finally, what is in it for the internist? You know, I trained in internal medicine and nephrology, and really, at least when I was in medical school, we were told that patients with preeclampsia, after the delivery, they're fine and they could go home, and this is a pregnancy-specific disorder. It turns out that's not true. Sort of every major epidemiological study has now suggested that if a woman has preeclampsia, she has long-term risk for hypertension and cardiovascular disease. You know, the risk is almost as high or even higher than hyperlipidemia or some of the other known risk factors for cardiovascular disease. These women with history of particularly recurrent preeclampsia are dying of premature strokes and cardiovascular disease. And I've shown a number of these papers that have, you know, first appeared in the BMJ and more recently several papers in the Lancet. And this is studies from all over the world, from Canada, from Norway, and also from Asia as well. And more recently, in fact, although the absolute risk is small, in fact, patients with severe preeclampsia, particularly recurrent preeclampsia, are also at they have increased incidence of chronic renal disease, leading to dialysis requirements. And interestingly, there's a decreased incidence of solid cancers in these patients. You know, particularly a large study done from Utah suggested they are protected from both ovarian cancer and breast cancer. And these sort of findings have, you know, made me think that potentially that these patients are programmed to make high anti-angiogenic molecules, and that and pregnancy is a stress test. And at a situation where the placenta is supposed to make anti-angiogenic proteins, maybe they make excess of these proteins that lead to preeclampsia, and that and as a result they potentially may be protected from cancer and may have more of this cardiovascular disease. Obviously this is a hypothesis, and our laboratory is actively asking the question, you know, can we identify specific genetic polymorphisms, you know, in the either in the genes themselves or in molecules that regulate these proteins, to ask the question, why are these patients you know, programmed to make such high levels of these proteins? Let me stop here and take questions. Obviously, this is a lot of work. Talented nephrology fellows in my laboratory, you know, Chun Lam and Sharon Maynard, who did most of the work. My mentors, Frank Epstein, who recently passed away. I really owe a lot to him because he really was the one who you know, made me work in this area of preeclampsia. Vikas Sukhatme, a huge help, primarily for pointing out this cancer literature and its relationship with hypertension, proteinuria. Pat Dumouriez lab for all the work in the, particularly the work in the brain and edema, and Michelle Letarte for work on the endoglin signaling. Cheryl Hodges at Beckman for some of the early work in trying to develop an assay in the blood that can be useful for preeclampsia, and Steve Pollard at SIOS, you know, for trying to develop a therapeutic for preeclampsia. Huge help from Richard Levine for all the epidemiological studies at the NIH, and tremendous help from both Ravi Thadani at the Mass General and the obstetricians back at the Beth Israel. Thank you very much. I'd be happy to answer any questions if there are any.
Hi, Bert Gold, NCI. Congratulations on your markers. I think that work is spectacular, and from my geneticist point of view, the trisomy 13 work is very, very interesting, and I certainly didn't know about it. I'm interested, when you write pro-angiogenic and anti-angiogenic, I'm translating in my mind, and maybe I'm wrong to do this, pro-inflammatory or anti-inflammatory, and I'm interested particularly in your reflections on Susan Hibby's recent work where she showed in the other Cambridge, where she showed that the HLA-C type may be extremely important for the trophoblast invasion, and that it may be an incompatibility that may stimulate this whole process.
Yeah, I think it's probably, of all the hypotheses out there, that's probably the most exciting hypothesis. The idea is that natural killer cells, and I don't know if the people here, you know, so let me summarize the work from Susan Hibby. These are natural killer cells that are typically thought to kill, you know, tumor cells or other infectious agents, but there are specific type of natural killer cells that are present at the maternal fetal interface that are actually, they build blood vessels. There's a very nice paper in Nature Medicine a couple of years ago that these decidual NK cells are different than the peripheral NK cells because they actually, rather than kill cells, they actually build blood vessels. And the paper by Susan Hibby refers to that potentially, there could be incompatibilities in the receptors depending on whether it's a stimulatory type of NK receptors or inhibitory type of NK receptors versus the type of HLA-C that it reacts, whether it's a C1 or C2 haplotype. I think these are questions asking at the proximal level, because what I presented is basically questions more at the distal level as to what's happening with the signs and symptoms of the disease. But these sort of ideas are related to what's really happening in the placenta. And I strongly believe myself that the NK cell abnormalities probably are playing an important role early on. And when you have abnormal NK cell signaling, and if you don't form blood vessels, then you create placental ischemia. And when you create placental ischemia, this in turn might lead to elaboration of these factors. Like we showed you in this primate model, where if you create ischemia, you can elaborate these, release these factors. So I think it's a very important question. I think that one has to get these DNAs and look at the haplotypes of babies and as well as the mothers and ask the question. And really, I think this is exciting work, and time will tell as to how much of a role that's going to play, in the actual genesis of the disease.
Yes, in terms of the production of the soluble receptors, so to speak, is there any evidence that in the preeclamptic models that you have that an increase of hydrolytic enzymes which would degrade the native protein to produce a soluble material?
There have been some reports that metalloproteases and things of that nature are increased in preeclamptic placentas, but with regards to soluble FLT1, at least we are quite confident that this in fact is an alternately spliced transcript. I didn't show you the northern data, but essentially you could see significant an RNA that's different than the full length FLT1 RNA. But importantly, more recently people have actually sequenced the circulating soluble FLT1 in the plasma. And because the circulating sFLT1, because of the alternative splicing, it takes an intronic piece. It has a certain unique amino acids that's not present in the full-length receptor, FLT1 receptor. And when you do a mass spec analysis of the soluble FLT1 that's present in plasma, you could see sequences from this intronic piece suggesting that this really is an alternatively spliced transcript, is an RNA that leads to protein. Unlikely that there's going to be significant proteolytic cleavage.
One more question. Have you looked at the levels of thrombospondin in the preeclamptic versus the eclamptic?
It's a great question, because Jack Lawler, who's right next door, has been asking the question. We haven't. I mean, thrombospondin would be a wonderful sort of one to look at. But Jack, who works on TSP, is right next door to me, and he's been asking me for like 3 years. We just haven't done it.
Thank you. Thank you very much for that very interesting presentation. A couple of questions, if I may. You pointed out to the increased levels of these anti-angiogenic factors in preeclampsia and the fact that they come down to normal after delivery, or at least they return toward a baseline. And yet you are talking about this continuous enhanced risk of complications, if you will, in the patient population that exhibited preeclampsia. Sure. So one question I have is there any alteration in the clearance mechanism for these proteins that are generated by the placenta, such that perhaps the levels in this subpopulation remains higher than what you would expect in the normal population?
We don't have any evidence for clearance. We really haven't looked at that. It's possible that some patients, maybe the reticular endothelial system is overwhelmed, maybe don't clear. But still, you're looking at, it should be cleared. If it doesn't clear in 48 hours, maybe it's cleared in a week or a month, but certainly not years. The question that you're asking is a very important one. What I believe is happening, for example, and this is some experiments we haven't published, we have taken preeclamptic patients and brought them to the Mass General GCRC a year, 1 to 2 years after the pregnancy, and so there's no placenta, and the baby's out. And if you take the circulating monocytes from these patients and expose them to hypoxia, for example, in culture, that the patients with a history of preeclampsia tend to make more soluble FLT1 in their supernatant compared to patients who are normal pregnant patients, suggesting that there's some underlying sort of machinery that is that's not working in these patients that allows them to always make this protein. And pregnancy is a condition where you're normally supposed to make enormous quantities, and so you can really see the differences. But maybe there's chronically locally in tumors or in cardiovascular tissues, maybe they're chronically making high levels. That could be one reason why they have more cardiovascular disease. The other hypothesis is that in fact preeclampsia is not a benign disease, that the vascular injury that one sees in the kidney, for example, doesn't heal. Maybe it heals completely with regards to proteinuria, but maybe even subtle, we've known at least in animal models that subtle renal injury can lead to later on salt-sensitive hypertension, and some of the injury may never heal. There's no real evidence for that, but we can look at that in these animal models. But I think the clearance question, we really haven't sort of looked at it. We haven't radio-labeled and asked, what the half-lives of that kind of experiment.
Thank you.
Hi. Do any genetic markers for preeclampsia map to the SFLT1 gene?
No. There's been some GWAS type of studies that have just started, and the Icelandic group has reported a locus in the chromosome 2, but really nothing, that's right on soluble FLT. They only accept the story that I told you about trisomy 13. So it could be that if there are other proteins that are genetically linked, maybe they are regulatory proteins, maybe splicing proteins or something like that that are playing a role in enhancing production.
Okay. Why is it that some women get preeclampsia with some pregnancies and not subsequent pregnancies, or like older age versus younger women?
So it's a good question. The reason is that the primary cause of preeclampsia, at least most people believe, as when the gentleman was asking the question about NK cell, is that the placenta undergo extensive vascular remodeling, so that the trophoblast actually undergoes extensive vascular remodeling, so that it allows more blood to go into the placenta. Now that vascular remodeling does not happen in preeclampsia quite early, possibly due to defective NK cell signaling or maybe other mechanisms. And so what happens is that the second pregnancy around, because you're starting at a higher baseline, your vessels have already remodeled quite a bit, and the second time around, you're starting with the vessel that's already 50% remodeled. It's easier to remodel the second time around. It's very much like labor. The first time, when the tissues are not ready for pregnancy, the labor can last as 20 hours, and the second time around is 4 hours, and third time maybe is 15 minutes. It's just the tissues, and it's very similar here, where the vessels are, typically the vessels don't have so much vascular remodeling problems. In other words, there's less ischemia second time around, and third time around there's even less ischemia. And we've actually done a small study with Ravi Thadani at the Mass General, where we looked at the first pregnancies versus second pregnancies, and at the same gestational window, and at the second pregnancies they make a 30% lower SFLT protein, the placentas, and we think that's because the vessels are, they started out with the already partially remodeled vasculature. And in fact, when you look at epidemiological studies, and if you, it's the inner pregnancy interval that's very important. So if you have pregnancies that are really, really short intervals, then you're really protected from preeclampsia. But if you wait long term, and then if you have your first baby, let's say this year, and then you have another baby 10 years later, then your risk to getting preeclampsia is almost back to first pregnancies, because by then your vessels have gone back to the virgin state, and so now you have to remodel all the way, starting from a virgin artery back to almost like a venous sort of like structure. And so I think the epidemiological studies suggest that the inner pregnancy interval is what is critical in terms of why patients with first pregnancies get more preeclampsia. And I think that this is probably a vascular issue. It's just that there's less ischemia. And at least from SFLT values, you could see that the second pregnancies there are lower concentrations.
Sorry, one last question. In your data in patients with trisomy 21, it almost seemed that they were protected against high levels of...
I'm not sure if this is an artifact or a statistical aberration, but this trisomy 21, it looks like there is, yes, this looks like slightly lower values. I don't believe there's any literature linking trisomy 21 with preeclampsia, but I don't know if there's no one's looked at it to see if there's a protection. But I don't think it's been looked at to see. There's no association between Down syndrome and preeclampsia. There's definite association between 13 and preeclampsia. I don't believe anybody has looked at the Downs literature to see if in fact there may be protection. No, yeah, it could be, yeah. I don't know.
Hi. You showed that the SFLT and S-endoglin were shown in the blood up to 2 months before symptoms were shown.
Yes.
I was wondering if you had any explanation for why it takes so long for symptoms and why.
Well, I just think that it's not just the acute level of SFLT1, it's the area under the curve. It's how long, even in the mice, if you give SFLT1, we don't, at least in our hands, don't get acute signs and symptoms. It takes a week or so to get the full-blown disease. I think it's really the area under the curve, I believe. And it's the same thing in cancer patients. When cancer patients get antibodies against VEGF or small molecule inhibitors, they don't get hypertension, proteinuria like immediately. It takes sometimes months. So it's probably you need chronic exposure, to neutralize VEGF, and eventually maybe, that's what at least we see in both animals and in humans. Well, thank you very much. Again, it's truly a privilege to be here. Thank you.